Thank you. That's we come to end of our session, and now we start the question answer session. I welcome Professor Hajazim here, Dr. Asad Pervez, Dr. Mubashir Chima online, and we are getting questions here. Dr. Asad Pervez, can you hear me? And Dr. Mubashir Chima also, welcome.
Thank you.
Dr. Asad Pervez, please, the panelist, please unmute yourself. Dr. Mubashir, the question is that which technique has a better cosmetic outcome, tissue-based or the flap-based or the implant-based after radiotherapy?
It will certainly be autologous, actually. It will be the person's own tissue. Because the problem after radiotherapy is that it causes micro angiographical changes in the microvessels itself, which increases the risk of capsular contracture. And the problem with that is that it hardens the skin, it makes it the tissue more firmer, and it increases the risks of complications. So definitely with radiotherapy, there is hands down implant-based is not the best solution. And I think that was the whole idea of my sort of talk as well. I mean, I can see I have a massive conflict of interest here that I prefer to do autologous anyway. But autologous will give you what you want, as much as you want within reason. And you have no worry about when to do the radiotherapy, how to do it. As long as you've got clear margins, you're safe. Okay? And the tissue will change with the patient as they gain or lose weight. I mean, of course, as Philippe Blondil's talk earlier mentioned, you might need lipofilling here and there at times, but that is a secondary procedure as opposed to having an implant itself.
All right. Dr. Asad Pervez is not here, but can you please answer this question that how we choose different flaps in breast reconstruction? What are the guidelines? Medical student asked us this.
I think that you have to match what you need with what you have. Okay, I think that's probably the simplest way of looking at it, and really, that's how I look at it as well. You have options that you can go for. However, the sort of standard microsurgical technique to do that effectively, what I've used for all the time that I was working in Oxford and other places as well, was using DF flaps. Okay, Philippe Blondil, again, he was one of the pioneers in introducing that to the world. And this is something that which some of my colleagues are able to do, again, single-handedly in 1.5 to 2 hours, ever so slightly longer than it takes a novice to do latissimus dorsi flap.
All right.
Okay, I have a question.
Dr. Talat.
I have a question for Mubashir. Thank you for coming here and joining us in this session. I'm very thankful to you. I have a long-standing friendship with you, and I'm thankful to you for that. How do you weigh between round versus anatomical implants in the breast reconstruction? What is your experience about it?
I would prefer to go more for the anatomical ones. Okay, if you've got the width in place, okay, as I said, anatomicals are ever so slightly lighter. They're about depending upon what size you're going for, it's anything between 10 to 15, maybe even 20% lighter as opposed to the round implants. You have to think that it's not just one breast you are reconstructing. You are aiming for symmetry with the opposite side. So you have to see what the other side looks like as well. So round implants, they give you more takeoff on a lateral profile. Round implants give you a higher takeoff and a more rounded shape at the top. However, the anatomical implants, they can still give you more natural looking, a straight upper pole, or what's known as. So it depends upon what you're aiming for, really. Okay, what shape you're going for, and how much space you have available. If you have a smaller implant, a smaller width implant in a wider chest itself, then an anatomical is pretty much guaranteed that it will rotate. So in that case, you'll go for a round one.
All right.
So you have to think not only just in 3 dimensions, you have to think in terms of symmetry as well.
Okay, thank you. There's another question.
And there is a lot of hue and cry about ALCL.
About what, sorry?
There's a lot of hue and cry about ALCL. What are the current guidelines about ALCL and lymphoma associated with the implants?
Okay, now the implant, the BILCL, that was most commonly associated with the Allergan implants, as well as the polyurethane ones. Both of those were taken off the market. The current data that we have is that Mentor implants, the risk is 1 in 60,000 implants. I mean, I tell my patients that is probably less than 1 in my whole surgical career. I mean, I'm not expecting to do 60,000 breast surgeries in my whole career, to be honest. Okay. The risk is not 0. That's the other thing as well. The thing is that when we did not know about PILCL, we had a lot more, or the world had a lot more advanced cases. But as the information has come through, we understand, excuse me, we understand that the problem is confined most of the time to around the capsule itself as well, but not further out. It only disseminates if you let it be. And an en bloc resection of the capsule as well as the implant gets rid of the problem and has very good results afterwards. Okay. That is, sorry.
That's great. And how do you choose between the local perforator flaps and LD-based reconstructions? I mean, if there are upper outer quadrant that is involved, then how do you choose whether it should be a local perforator flap or LD-based reconstruction? I mean, what is your experience about it?
I think it depends upon the surgical expertise. Okay. What I like to think of is that all these flaps, options, implants, they are sort of tools in your toolbox. Okay. You pick out the tool that you're most comfortable to use. Okay. Now, as I said, DF is pretty much the standard of care for autologous breast reconstruction in most of the places, in most of the center of excellence that I have worked in and known and done myself. But if you're not comfortable with, or if a colleague is not comfortable with microsurgery, you don't have the microscope or the sutures or any expertise or experience, then even then, LD is a safe option. Okay, it is large, it's easy to raise, it's open. That's the reason I specifically cited it. That why don't we? If you're not comfortable with microsurgery or anyone is, then LD is a reasonable option to at least start autologous reconstructions with. Okay. And again, my conversation, I think previously when we had as well, that if you are happy with your way around the recurrent laryngeal and the superior thyroid, believe me, raising a perforator flap isn't that difficult. And if you talked about the upper outer quadrant, actually there is something right around the corner that you can raise a perforator from the lateral chest wall as well to cover. That can give you easily about 100 cc or 100 ml of volume there. So it is sort of knowing your options and what to do, plus matching up with the surgical expertise as well.
Yes, thank you so much, Dr. Mubashir, for so elaborative answers on the flap reconstructions. We have our co-chairperson, Professor Fajar Azim, with us. Sir, kindly please tell us about what's your views about this session. This is a wonderful academic session we just had. Please share your views.
Assalamu alaikum. Thank you very much. It was a very knowledgeable session and that adds a lot of knowledge to my knowledge, because we are the people who are in the opinion of the modified radical mastectomy for advanced breast cancer, because majority of the patients who come to us is stage 3A or stage 3B, which may or may need neoadjuvant chemotherapy, or the inflammatory breast cancer, which needs neoadjuvant followed by modified radical mastectomy. But breast reconstruction and breast conservative surgery is now a new to us, because in our society, majority of the patients, they are ignorant. Even the educated people, they don't have the idea what is the breast cancer. And especially in the villages or in the countryside, I think this is a new modality and it should be done, because this is not a new one. Even 100 years back, George Cryle was the person at that time when the William Halsted was there. A simple mastectomy will be better as compared to modified radical mastectomy. But the influence of William Halsted was so much that nobody tried to do the simple mastectomy up till 1957 or even 60. Later on, this McWhorter from the Royal College of Limerick, radiotherapist, he uh, attributed the simple mastectomy followed by radical radiotherapy. Now it has further come down to breast conservative surgery if the lump is 4 centimeter or less. Nowadays, they can even use the neoadjuvant therapy for downsizing the primary tumor. I think I got a lot of knowledge from you people. You guys are very knowledgeable for us. And one thing is very important for us, that this should be spread to our other colleagues also in Pakistan. Unfortunately, there is no too much message about the breast cancer to the society, and the people, they come late, not only on the countryside or village side, but also from the city. They are hesitant. You will be surprised, the educated people, they have got stage B till the tumor fungate and ulcerate and bleed. Then they come to us. And they are well-educated people. I don't know why it happens, why they don't help us. So I think it's a wonderful talk, and I have learned a lot from your this knowledgeable sessions. Thank you very much.
Thank you. I would like to thank all of my respected guests, and this is a wonderful session, wonderful chat. Thank you so much.
Thank you very much,
Thank
all.
you. Thank you very much.
Thank you, Mubashir. I am very thankful
Thank
to
you.
you for spending some time for us. And I would like to extend my thanks to Professor Philip Blondel. He has COVID, and hopefully he will be fine, and we will be able to see him in future. I would also like to thank Evan Metros. He spared some time for us. I would like to say thanks to Dr. Amina, as well as Dr. Huma Majid Khan and Dr. Asad Parvez. Your talks were phenomenal, and we are always thankful to you for sparing some time for us. And this was an excellent academic activity, and we will be continuing in the future. Very thankful. I am very thankful to you all. Thank you.